This patient presented with an increasing mobility of the maxillary right lateral incisor. She had a history of orthodontic treatment for a number of years, which resulted in shortened roots. Since her employment required frequent speaking engagements, the treatment plan was to remove the tooth and place an implant with an immediate temporary restoration. A diagnostic guide was made and cone beam x-ray was taken without removing the tooth. The images were evaluated and in vivo 5 software indicated the site would require augmentation prior to implant placement. The diagnostic guide was corrected using the GuideRight protocol. A periapical x-ray shows the shortened root of the lateral incisor. The first step in the GuideRight protocol is to take an impression and fabricate a diagnostic guide. A hole was drilled in the cast in the cingulum with a 3/32 drill. The long axis of the hole represents the planned implant trajectory. The diagnostic guide can be placed without removing the tooth. A 3 mm straight guidepost is placed in the 3/32 hole. A 3 mm guide sleeve is placed over the guidepost with the cleats positioned toward the lingual surface. The cast and several of the adjacent teeth are lubricated with petroleum jelly. Triagel is added to capture the cleats on the guide sleeve and several of the adjacent teeth to form the diagnostic guide. The diagnostic guide is removed from the cast, placed in the patient, and the cone beam x-ray is taken. In vivo 5 software is used to analyze the images in the cone beam x-ray. A virtual implant is selected from the implant library. It is placed in the image, aligned with the guide sleeve in both the mesodistal and buccolingual view. The home position is the position a virtual implant is in when the long axis of the implant is centered in the diagnostic guide sleeve in both the buccolingual and mesodistal plane. The line in the axial view represents the buccolingual plane being observed. It should be at 90 degrees tangential to the buccal surface of the alveolar ridge. The upper left corner of the image indicates the axial view. The line observed represents the plane being observed in the cross-sectional view. The adjustable line, which can be rotated with your mouse, should be set at 90 degrees to the plane of the arch. For a better understanding of the use of in vivo 5 software, see Steps to Making and Correcting a Surgical Guide at our website at deplaque.com. If we look at a higher magnification of the cross-sectional view, we can see that the diagnostic guide cannot be used to place the implant. The results of the cone beam x-ray indicate there is a buccal concavity which will need to be grafted prior to implant placement. An intrasulcular incision is made and a full thickness flap was reflected. A full thickness flap was reflected to a depth of 12 mm for the placement of the bone graft. The buccal concavity was grafted with 50 micrograms of BMP2 and Puros. The patient was from out of state, so the site was closed with resorbable sutures. The site was allowed to heal for 6 months prior to implant placement. A virtual implant is selected and placed in the software. The home position is the position where the virtual implant is aligned with the guide sleeve in both the tangential view and the cross-sectional view. In the cross-sectional view, the bone inadequacy in the buccal can be observed. Both the angle of the implant and the linear position of the implant must be corrected. A virtual implant is placed in the software in the most desirable position. The angle tool in the software is used to measure the angle formed by the long axis of the implant and the long axis of the diagnostic guide sleeve. The angle measures 32 degrees, thus the correction will need to be made 32 degrees in the guidepost. The linear offset correction is 2.5 millimeters, 1/2 the length of the grid square. In the in vivo 5 software, each grid square measures 5 by 5 millimeters. A 2.5 millimeter offset guide post is selected and a 32-degree angle correction will be made. Both the angle and linear corrections were determined using the information from the in vivo 5 images. The surgical guide was fabricated in-house using a two-piece 2.5 millimeter offset guide post. The angle of the guide post was corrected 32 degrees by bending it with the bending tool. Utilizing the information from the cone beam images, a 3 millimeter guide sleeve was chosen to guide the osteotomy in preparation for the placement of a 3.3 by 10 millimeter tapered bone level implant. This is a close-up view of the offset guide post used. The stylus is used as a lever to bend the guide post 32 degrees. And a 32-degree angle correction is made. The next step is to fabricate a new surgical guide. The 32-degree guide post is placed back in the cast. A 3 millimeter top part is selected for the two-piece guide post, and a 3 millimeter guide sleeve is placed on the top part, with the cleats positioned toward the palatal. This is the buccal view of the guide post and sleeve aligned between the two adjacent teeth. Sticky wax is applied on the palatal surface to prevent the guide post from rotating while the triad gel is added. A small amount of triad gel is added to the cleats and the adjacent teeth and cured. This is the occlusal view of the surgical guide after the 3 millimeter guide post has been removed, leaving the bottom part of the two-piece guide post. 6 months later, a second cone beam x-ray was taken to verify the results of the grafting. A 3.3 by 10 millimeter implant is selected for placement. The results of the bone grafting and the alignment of the corrected guide sleeve position indicate osteocondensation drills will be used during the surgical procedure. The cone beam image in the tangential plane indicates the alignment mesial-distally is satisfactory. The next step is to anesthetize the patient, remove the lateral incisor, and place the implant. The surgical guide is inserted, being sure that it is seated on the adjacent teeth. The initial drill used is in the 3 millimeter guide sleeve with a 2 millimeter drill with a 3 millimeter diameter by 10 millimeter depth stop. The osteotomy was widened using 2.3 and 2.5 millimeter drills within the 3 millimeter guide sleeve. The depth of the osteotomy is checked with the surgical guide removed. While the drill is running in reverse, the bone is not removed but condensed during this procedure. A tapered Straumann 3.3 by 10 millimeter bone level implant is placed, allowing the implant to follow the axis of the osteotomy. A torque wrench was used for the final placement of the implant. The level of the implant is checked with a periodontal probe to be sure it was placed 2 millimeters below the level of the alveolar crest on the buccal surface. An Ostel smart peg was placed to check the implant stability quotient, which was 65. A periapical x-ray was taken of the Straumann implant after placement. An impression was taken in case a new temporary restoration might be needed to develop the soft tissue contours 6 to 8 weeks later. A short healing abutment was placed to keep the implant site open for the immediate temporary placement, completed on the following day by Dr. James Soltis. Three months later, the final restoration was placed. A scanning electron micrograph of the Puros shows the collagen fibers necessary for the BMP2 to bind to.